You would do it. You would do it. Let's just start the show. Let's just start the show.
I agree.
I
Let's
have
just
stuff
do
to
it.
say.
Yeah. Let's just do it. All
Let's
right.
start the show.
Ladies and gentlemen, welcome to another episode of the Women's Health Podcast with Kim and Dr. C. Of course, you know I'm Dr. Leroy Campbell, the Women's Health Doc, Dr. C, and I'm here with my beautiful co-host, Kimberly Hoffman-Reed, the Women's Health Physio. Kim, how are you?
I am good, Doc. It's good to be back. It's good to see you. You know, everybody think I see it all the time, you know, and they don't know that I need this show as much as they need this show so I can see and chat with my great friend.
Listen, it's good. It's good. It's been a while and a whole heap of different stresses and pressures, but we have to find some time for this and some time for us to
Absolutely.
chat, as well as put something out there that's going to be beneficial to the women out there and those who love and care about them.
Yes, that is important. And I mean, while we're on break, a patient who I haven't seen in a long time came in and she was telling me how, because of our podcast, you know, she didn't even say, oh, she was just like, I didn't know until I listened to the podcast. And I'm just like, I just thought it was a random podcast. And then she was like, yeah, the one that you did with Stephanie. And I'm like, oh, that's my podcast. And she's like, yeah. I'm like, oh, did I send it to you? And she's like, no, my sister overseas was listening and she sent it to us. And I'm like, what? So, you know, it was good to know that our work, it's getting traction and it is actually helping women. So, you know, we have to keep it going, keep it going.
Yeah, definitely. We have to. We have to. All right.
Yes.
So, Kim, listen, you know how it goes. You have to give me the scoop. What's trending now in social media? I've not been on Instagram, TikTok,
I know because
anywhere
I've
in
sent
so
you a
long.
bazillion things and not even a little flinch. There have been so
Ooh,
many things.
ooh.
But this morning I saw something pretty good and it's related to
Mhm.
Jamaica. The NHF health card now subsidizes pap smears. And I
Okay,
thought that was pretty good. I thought that was pretty awesome.
good.
I know a lot of women feel like the NHF card's not very useful to them because a lot of the things that we absolutely need, they aren't subsidized. You know, they have instances where the same medication, males use it for prostate cancer, I think, and women, I don't remember what they use it for. It's not available for women, but it's available for men on the NHF. So a lot of discrepancies there. So I'm happy that they're trying to rectify that and give women more access using the NHF card. Yeah.
Yeah, that's good. And for those who don't know, NHF is National Health Fund, right?
Fund, right.
National Health Fund, which provides subsidization for medical costs, particularly medications, to many Jamaicans who qualify. So that's good.
Right.
That's good. Yeah. I
It
think
is. It is. It is.
certainly from a gynecological standpoint, there are a number of drugs that we do use that for women, you know, especially in treating like endometriosis and so that also are utilized in prostate cancer treatment.
Right. Yes.
And
Mhm.
then these are really hormone modulating medications, and yet women can't benefit from the same subsidies that men benefit from. So
Yep.
hopefully this is an indication of us going in the right direction. So I'm very happy about that.
Me too. I am. I truly am. But Doc, I'm going to throw my business out there a little bit because I want us to discuss something before we start discussing the main thing.
Okay.
So, I was at the pharmacy, right? And was going to get an emergency contraception, right?
Mhm.
And the pharmacist said, oh, if you're near your period, you don't really need this. And I'm like, no, I think I do need it. And then she's like, oh, but if you're ovulating, it won't work. So then that blew my mind. That absolutely blew my mind because I'm like, um, then when would a woman need it? When would a woman need it if not when they're ovulating? So if there are other women out there confused, just as confused as I am, because this is why we have this show. If there are other women out there just as confused as I am, I would like you to clarify what the pharmacist was trying to say to me. And if that is so, then if what she's saying is accurate, then emergency contraception a waste of time?
Uh, no. I can't. I won't say I clarify what the pharmacist was saying to you because I mean I'm not sure what the pharmacist was saying, but Yeah, so emergency contraception works in a number of ways. One of which is to that they may actually block ovulation, yes.
Mm-hmm.
But it doesn't mean that they can't be of benefit if a woman is in around the time of ovulation, because they also can have a negative impact on the implantation of the egg. So even if the egg is
Mm-hmm.
fertilized, they quite often, if you notice after taking the emergency conception, there may be a little bit of a bleed or so, withdrawal effect, which sheds the
Right.
lining and affects the implantation. So certainly, women would benefit um, from having emergency contraception. They are very effective methods. Eh?
That's what I thought, but I was just like, if it's not when you're ovulating, then when? Then when? When
Yeah.
would you need it? When would you need it? So, and that brought me back to my constant point of persons not knowing enough about their cycle and about the woman's body, because that is really the only time a woman should be worried. Close to ovulation or right after ovulation would be the time that you'd be worried. But outside of
Hmm.
that, it's less likely that you can get pregnant. So when a pharmacist will be like, oh, if you're ovulating, it might not work. That's that's like, oh, really? Then I don't need this. But you're saying that's not true.
No, no, no.
Not saying what the pharmacist is not true, but just saying my interpretation of what she said is not true.
yeah, yeah. I mean, if that's what she was trying to say, then no, that's not accurate. Especially if you're used there, what's important also to recognize that the different types of emergency contraception and what we're referring to in this
Mhm.
particular case, I'm assuming, is the oral pills, specifically the progestogens,
Right.
which these would contain a progesterone-like hormone called levonorgestrel for the most part. And these can be used up to 3 days after
Mm-hmm.
unprotected intercourse, right? Um, and the good thing about these is that it's widely available. Women don't need a prescription. They don't need to go to a doctor. So it gives the woman the power to be able to access that. And of course, if she needs ongoing contraception, she can then just continue oral contraception if she has selected that method going forward.
Right.
So these are very useful tools for pregnancy prevention. And certainly I would encourage women who are at risk to use them, if it is
Not
that,
all the time. Emergency, not an
yeah,
ongoing form of
not
contraception.
for not for long term. I'm glad you said that because I've seen that as well, where
I
many
have
women
two.
just, yeah, they become serial abusers of emergency contraceptive methods, and that's not really healthy. First of all, it's going
Reduces the
to
effectiveness.
effective, and then invariably, remember now, these methods are not 100% effective
Mm-hmm.
of preventing a pregnancy. Okay.
Right.
Um, and so what you're going to find is that at some point in time, you may find that it may fail, you know,
Yes.
and then on top of it, it also may throw off your menstrual cycle. So it's important, if you find that you're needing to use emergency contraceptive more than once, that you probably should be on some kind of long-term
Probably.
contraceptive method.
That would be wise. Okay, so thank you for clarifying that for me, Dr. C. And I'm sure
Mhm.
other persons probably thought the same thing, or they thought nothing of it, but now they realize that, hey, I probably don't need emergency contraception if I'm not at ovulation or close to before or after ovulating.
Right, right.
So now, Doc, I've been having quite a few women post endometriosis, post surgery for endometriosis, right? Whichever surgery
Mhm.
it might be. And their their expectations after surgery, it's typically that after surgery should not be feeling any pain. And if they were having pain before and they did a surgery, it was supposed to solve all of that problem. And
Right.
they're typically very disappointed if that's not the case. And I don't know if it's a case of the expectations not being clearly explained before, telling them what to expect after in terms of the recovery period. I'm not sure where the gap is, But I've had quite a few women, they come to me for like to help for work on the scar tissues after surgery. And their expectations just like they shouldn't be feeling any pain. They shouldn't be having discomfort. All the problems that they had before should be gone. And I've not seen where that's the case. Maybe less pain, but not completely gone, has been my experience with my patients. And it might be skewed because the ones who don't have pain wouldn't come to me. So, so also bear that in mind. So yes, doc, I would like your feedback on this because it's a surgery that you would do for your patients as well. And what's the typical expectations after surgery, and how do you prepare your patients for what is to come after?
Yeah, I think so. So pretty much, Kim, what you're talking about is the fact that many women who you have seen have
Mhm.
undergone surgical treatment of endometriosis, and many of them still are having significant symptoms, which in most
Right,
cases some kind of pain-related symptom. Got you?
right.
Yeah. So I think before we can even talk about surgery, we have to be careful not to lump everything into a category because there are
Right.
different types of surgeries that we can offer to
Mm-hmm.
women who have endometriosis, right? Um, when we talk, first of all, the only definitive surgery that will cure endometriosis is to do what we call a total hysterectomy plus bilateral oophorectomy, salpingo oophorectomies. And what that means is a surgery that involves removing the uterus as well as the ovaries. Okay? That is the only surgery that really is curative. All
Wow.
right. And it's important for us to understand why that is the case. That is the
Mm-hmm.
case because, as we've spoken about many times before, endometriosis is really a condition where the tissues that line the inside of the womb have found themselves in other places that they shouldn't be.
Right.
So, for example, in the pelvis, around the womb, on the ovaries, in other parts of the body, right? But the most common site is within the pelvis, in and around the area of the uterus.
Mm-hmm.
And so that now is what leads to the whole process of the symptoms that are related to endometriosis. Because every time a woman goes through a menstrual cycle and she goes through a menses, those tissues shed and bleed just like the ones on the inside of the womb. All right.
Mm-hmm.
And so you have bleeding inside of the abdomen, though. The tissues that are in the uterus, when they shed, blood comes out through the cervix and empties out through the vagina.
Right.
The tissues that are inside the body in the pelvis there's no way for that blood to go when it sheds. So it eventually is absorbed, but before that, it does create some inflammation. And it is
Mm-hmm.
that inflammation that leads to the sequelae. Most of the sequelae are issues related to endometriosis, meaning pain, also scarring, which
Mm-hmm.
leads to not just painful periods, but you may have pain before the periods, you may have pain during intercourse, those kind of a thing. Um, and in some cases, you may have endometriosis in the ovaries, and that the blood gets trapped within the ovarian tissue. And over time, you get a cyst in the ovary we call an endometrioma. All right.
Mm-hmm.
So those are some of in a nutshell, what the underlying issues are and what the potential complications are. Now, if we understand that then, and we understand that the whole menstrual cycle, the whole process is driven by the hormones that are produced by the ovaries,
Mm-hmm.
we can understand then that any procedure that does not remove the ovaries has the potential for recurrence of symptoms.
Mm.
Does that make sense?
It does. It does.
Right. So that's where we say we're talking cure, that's where we start. Now, when we get into the other surgical, now obviously that's not going to be the treatment for every patient because the majority of women who have endometriosis are young women of
Young
reproductive age
women, right?
who have reproductive ambitions.
Mm-hmm.
So nobody in their right mind is going to go around be doing a hysterectomy oophorectomy for every single woman who has endometriosis.
Right.
And so now, when we talk about alternate surgical methods now, there are a number of different surgeries that can be done in that context. So if, for example, the main problem that is diagnosed is an endometrioma, which is a cyst in the ovary, the surgeon may go in to do a cystectomy or removal of the endometrioma, right? If the problem is believed to be endometriotic deposits in the pelvis, then they may go in and either ablate, meaning to burn or destroy those deposits, visible deposits, or do what we call stripping, which is where they remove the lining, the tissues lining the inside of the pelvis on which endometriosis has deposited. You understand? These are called resection procedures. So you can remove the individual things, or you can strip away the peritoneal lining with the endometriosis attached. And then you have procedures that actually treat the nerves that give supply to the pelvic structures, right? So there is a particular nerve, for example, that runs from the spine to the uterus, right? And that's the uterosacral nerve. And you can do procedures where that nerve is either cut or burnt, ablated.
Right.
You understand? So those are that's in a nutshell the varying surgeries that are offered, that are usually offered, right?
Yes.
In terms of treating endometriosis. Right? And then you have surgery that is offered for the purpose of just diagnosing.
Right.
Right? So
just looking.
the most common diagnostic surgery is called a diagnostic laparoscopy, which is where we put a camera into the abdomen and we look around to make the diagnosis, but there's no treatment. Okay? So first of all, when we're talking to patients, we need to identify what kind of surgery was done.
Are we doing? Yeah.
You understand? And a lot of the times, I think the problem starts with education and the preparation of the patient. I think most times it's really where patients have not been, their expectations have probably not been adequately managed. You understand?
Absolutely.
So
Absolutely.
if we begin to talk about the different surgical options, then you're going to find that if we start with follow-up of patients who had like a hysterectomy plus removal of the ovaries. So they moved the one
Yes.
the first definitive surgery, uterus plus ovaries. And you follow them up, usually by 7 to 10 years, well over 90% of them would be absolutely symptom-free.
7 to 10 years?
Yeah, no, I mean, if you follow them up at 7, at an interval, right?
Okay.
So usually, those patients tend to do well, in other words. So mean even after 7 to 10 years of following them up, the majority of them are still going to be symptom-free. Let's put it that way.
Okay.
Now that it takes 7 to 10 years. I'm just giving you a perspective.
Better.
Yeah. So most times we'll follow up at 2 years and we say how the patient feels at 2 years. But as I said, this is definitive. And so even after that, the patients tend to do well. And because it makes sense, right? The patient essentially is now in menopause.
Right.
And there's no longer the hormones that are driving the growth of the endometriosis.
So basically, even after surgery, even after the definitive surgery, the patients, they need to understand that they have to wait some time while the body is still regulating the hormones for them to actually become pain-free or not have the symptoms of endometriosis?
No, not necessarily. I think if for example, in cases where there's a hysterectomy and removal of the ovaries, once the patient recovers from the healing process of surgery, they tend to have resolution of their symptoms.
Okay.
Because remember, they're no longer menstruating, so there's no longer the menstrual pain. Hopefully, the surgery would have helped with the scar tissue that was there.
Yes.
And then there's no longer ovarian production of these hormones that drive the growth of endometriosis. So
Okay.
that is essentially curative for most, if not all, patients. All right.
Right. So the only issue they would probably have, it's the healing process. The scar tissue is from surgery, not from
From surgery. Ah,
endometriosis.
excellent.
Okay. Mm-hmm.
Excellent. All right. So then you have one of the next group now are the patients who we say, okay, doc, I don't want to have any more babies, but I need to get rid of this pain, but I'm not yet ready to go into menopause. So there's a young woman, achieved childbearing fertile objectives, but she not, there are disadvantages to going into menopause too soon.
Mm-hmm.
You understand? Cardiovascular risk increases, bone loss increases, osteoporosis risk increases. So now, such a patient may opt for a hysterectomy, but may not necessarily want their ovaries removed.
Right.
And in that case, you will probably find that the majority of them remain symptom-free and are fine. Probably well over almost 80% of them remain symptom-free. But then you're still going to have some who may develop recurrence of symptoms. All right?
Right. Because the ovaries are
Most
still
time,
there, the
because the ovaries
hormones
are
are
still
still
there,
there.
and endometriosis
Right.
can continue. So they can come back, for example, with cysts on the ovaries and so forth. And I've had patients who I've seen like that, whether, fortunately, most of the time it's somebody who have had surgery elsewhere and is coming to see me because they're now having issues related to that. All right, so like
Okay.
ovarian cysts and so forth. Right. So now those patients, now we're saying in 80% of the cases, 77 to 80% of the cases, those patients are going to be fine. Right?
Okay. Mm-hmm.
Okay. So now let's talk the patients now who undergo what we call excisional procedures now. Right? In other words, patients now who we're just going in to try and remove endometriotic
Some
deposits
scarring.
or to burn them and so forth. And in those cases, as you'd expect, the recurrence rate is going to be higher, right?
Yes.
And a lot of these cases, up to 20% of them may actually require repeat surgeries in the future, sometimes that's within 2 years. So you're going to find that the likelihood of recurrence depends on the kind of surgery. You see the difference now?
Yes, I
So
do.
if we're doing this excision alone, then only about 45% of them are going to remain symptom-free after between 2 to 5 years or so. If you're
Yes.
doing hysterectomy and keeping the ovaries, then 80% of them will remain symptom-free. And if you're removing the uterus and the ovaries, then well over 90% of them are going to remain symptom-free.
Symptom-free.
You
I
understand?
can understand that. Yes.
Yeah.
I
So
can
what you
understand that.
find there for Kim, well, before I make that point, because I feel like I've been talking a long time, let me just make sure that you're clear on everything and clear up anything that I might not have been
No,
pristine in my explanation of.
you've been super clear. You've been super clear. So it does come down to the type of surgery that the doctor and the patient decided on. Um, However, I want to bring it back to like a case base, right? So say there's a patient who she didn't have, she probably was a unicorn example, but she didn't have any pain per se, meaning her periods were relatively normal. She didn't have any clues that she may have had endometriosis. However, she's about 43 and she started to have some pain after peeing. That was her first sign, just some discomfort every time she peed. It wasn't even extremely painful, it was just becoming more and more noticeable. So then she goes to the doctor, then she's diagnosed with endometriosis, and apparently it's extremely bad. She didn't know this because she was on birth control pretty much her whole life, so she had no real symptoms that she was aware of, just this peeing pain. So she does the surgery because the doctor is saying this is really bad. You know, you have all this scarring and the endometrial deposits, they're pretty bad. You need to remove them. She does the surgery. Now, after doing the surgery, she has way more than the pee pain. She has way more than the pee pain, and she's maxing out all her options, trying to get back some normalcy in her life. Now, she's not someone who was having extreme periods or so there has been absolutely no benefit for her with doing the surgery. So for me, that is a case of just not being adequately informed before surgery because she just went in to try to fix her pee pain. And now she has a whole host of problems that she never had before. In instances like those now where probably the next option is actually doing a more definitive but
Definitive.
the word is eating me up.
That's
Definitive
fine.
surgery. um, who might be opposed to doing surgery because in her head, no,
Past
surgery
experience.
ruined her life.
Yeah.
You
Yeah.
know, how does one, because you've spoken about patients who they saw a doctor before and now they're coming to you after. Um, say this patient was supposed to come to you, how would you approach such a situation?
Yeah. Yeah. So I think the first place to start is, Kim, as I said, medicine is first like good detective work. So it goes through the history, which you have given a very, detailed history of that patient. And then the next step is really education. So you have the investigation, which is the detective work, doing the history, the exam, whatever investigations, tests you need to do. And then after we do the investigation, now we're going to once we have come to our conclusion, we're going to education now.
Mhm.
You understand? And after we've gone into education and we've decided on our course of actions, we have to manage expectations, right?
Right.
So in a patient like this, and this is often not an unusual problem. It's not a unicorn thing. It's not isolated, to be honest. It happens fairly
What?
often. Yeah, it happens fairly often. Many of the patients that I have seen who come to me having been treated for endometriosis before are patients who may have had 1, 2, 3, 4, 5 surgeries.
Wow.
You see, and so by the time I see them, they tend to be very resistant. A lot of the times they're coming because somebody has told them to come, or they're coming because they're desperate. And there is a level of skepticism that they have about whether or not they can be helped, because these are
Mhm.
women who essentially have been suffering in pain to the point of people thinking they have mental illnesses.
Mhm.
Because what happens with endometriosis is that a lot of the features of endometriosis you can't see on ultrasound, can't see on imaging. So even if you the ultrasound or even the MRI or CT scan or whatever imaging, you may not necessarily see it. And
And then
so,
gaslighting
yeah, yeah,
you.
and so yeah, and then sometimes the physicians get frustrated too because boy, this lady coming to me every minute back and forth, and they themselves get frustrated. So there is always this very high sense of tension that exists a lot of the
Mhm.
times, when I have such cases. So I think one of the first things to do is really just to talk and figure out have a discussion about what's going on, and then now begin to educate the patient. Because
Right.
what you're going to find is that the majority of women, if you give them adequate education, the whole process of selection of a therapy becomes easier.
Mhm.
So I'm not telling you what to do. I'm educating you, I'm empowering you, I'm giving you the options available, and then you can literally, as we sit down, begin to figure out, oh, that sounds like something that can work for me. That sounds like something that can work for me. You understand what I'm saying? And what one of the things you find is that certainly for me, I'm not, when it comes to selecting surgery as an option, I'm not necessarily one of those people who's going for surgery first. I enjoy operating. Don't get me wrong. I enjoy being operating room is a place of peace for me. But is it the best thing for the patient?
Right.
You get what I'm saying? Because surgery itself carries risks.
Exactly.
You understand? So when you're going in for surgery, yes, you're going to solve a problem, but understand that in going to solve that problem, you can create other problems too. Especially
Precisely.
with endometriosis because of how complex the surgeries often end up being. These women have a lot of scar tissue sometimes. and you may have bowel involved, the bladder might be involved. So in
Yeah.
going in, the risk of injury to other structures is higher than for other patients. You see?
Mhm.
So now you might go in now and then you do that. And then on top of it, because the process of endometriosis cannot be cured by surgery unless we're removing the ovaries, as I told you, you now create another source of inflammation apart from the endometriosis itself.
So you have two sources of
So the
inflammation.
surgery itself creates a source of inflammation. Remember that? So you have
Yes.
adhesions and scar tissue from surgery, plus the
Right.
effect of the endometriosis, which has not been cured.
Right.
You see? So it's not that surgery doesn't have a role. Don't get me wrong. I'm not anti-surgery. I don't want anybody to feel that. Everything has its role.
Absolutely not.
But
Yes.
it's not as cut and dry. You know, I remember
Mm-hmm.
back in the day when endometriosis was really becoming something that we were really realizing as physicians. We used to be very gung-ho on surgery. I mean, people come in, all right, we need to do surgery to diagnose you. And then you go in, they need to do
Exactly.
surgery to treat you.
To treat you.
Yeah. And a lot of women ended up in the same situation, having 1, 2, 3 laparoscopic procedures, and they're still not better off. You see? So, but there are methods, there are approaches that you can use to manage the patient in that situation. I don't know if you want to go into all of that, but the first thing,
I
as I said,
actually
is
do. I actually
investigation,
do.
have the discussion, educate the patient thoroughly so she understands what's going on, and then now working with her now to find out what's the best approach.
All right. So, for instance, if a patient, if she's at reproductive age where she doesn't want to remove her uterus or her ovaries, but she still wants to manage her pain, right? She's probably inclined to remove them after having a child if she doesn't have one and she really wants to. And we understand that there will probably be some amount of pain that she will experience. Do you believe that there is room for mental health therapy where they can get help in terms of managing chronic pain? Because I find that that's a key aspect that's probably oftentimes overlooked because it cannot be easy not being able to function at your optimum day after day after day. You're waking up, you want to do so much, but your body's just not capable of doing so much. Persons are looking at you and they're not seeing the pain that you're feeling. So they're like, why is she just there? Why is she not doing anything? That must take a toll mentally, and you can either succumb to the victim mindset, or it can cause some form of depression, or you probably get burnout trying to power through. What's the role that you believe, or do you work with mental health therapists in order to help these patients with endometriosis?
Yeah, Kim, I think you're absolutely right. I think the management of endometriosis requires a comprehensive multidisciplinary approach. And I say
Mm-hmm.
multidisciplinary, it's not just a gynecologist alone that's going to solve the problem. Very rarely is any one gynecologist equipped to deal with everything. You need the psychological support. You need also the physiotherapy support. You know that. We've spoken about the issues related to muscle spasms, disruption in the whole muscular equilibrium of the body, which leads to
Mm-hmm.
the chronic pelvic pain syndromes, apart from
Right.
just endometriosis. So it's a multidisciplinary thing. What happens sometimes is that the availability of support for things like situations like this is not always great, and also patients' willingness to access certain aspects of care because of stigma can affect that.
Yeah.
Certainly in my practice, I've found that unfortunately or fortunately, I've ended up doing more than as a
Being the
gynecologic part,
therapist.
being the therapist to some extent, which 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 is well intended because the patients do benefit from that, but it has its disadvantages. For me, it's that
Yeah.
my consultations take longer, right? You know how long goes, how that goes. and
We
then
know.
and then for the patient, maybe there's somebody out there who is better at managing them from a psychological standpoint, because of course
Yes.
that's not my area of
Yeah.
expertise. So
Right.
I would certainly want to see that become more of a part of the standard care, because I can tell you the evidence shows there's a link between conditions like endometriosis and underlying and psychological disorders such as depression, such as anxiety. Um, also we know the effects on productivity,
Mhm.
and so forth. So yeah, definitely.
Yeah. And also in managing the pain, because as physios, we there's the approach of the neuropsychological or the pain neuroscience, really,
Mhm.
where your body gets so used to feeling pain, it can feel pain even without a stimulus. So
Right.
just understanding that as well without patient thinking that you're saying they're not having pain. Because it's
Mm-hmm.
always so sketchy to be like, pain is in the brain. They might say, wait, she's saying I don't have any pain. But
Mm-hmm.
that's not what
Mm-hmm.
we're saying. We're just saying that the pattern of pain is now lodged in the brain, where your brain
Right.
just decides that, oh, let's send out pain signals when you're not even really having a stimulus. So that's also something that we need to retrain. And the appropriate tools a physiotherapist might not have, a gynecologist might not have. And that's where we need the psychologist or the neuropsych therapist. So yeah, so I really do believe that that's an avenue that it's not properly utilized. They're there, but it's not properly utilized in terms of the management for endometriosis.
Yeah, definitely. And I think as time goes by, we're going to really begin to appreciate more the comprehensive approach to these things. Um, Certainly in my ultimate goal or desire would be to have that kind of environment where physiotherapy is working right side the gynecologist side, right beside the psychotherapist, and we are,
Don't tell everyone our dreams.
okay, all right, fine, don't worry, I'd edit that out.
I'm joking, but yeah, that would be the ideal world, my utopian just vision of women's health care. That will definitely
Right.
be the holistic approach that we would take. But is there room also if the doctor says that you're gonna have some amount of pain, that also allows the patient to not freak out every time they feel pain and in turn have more pain because the body is now tense because why am I having this pain? I'm not supposed to be having this pain. Versus the doctor saying, okay, every now and again, you might feel some pain. And now you expect that and you go, oh, that's the pain the doctor said I might feel. And you go about your day. Because I even find that with chronic back patients, if I said to them, every now and again, you'll have a flare up, but just do X, Y, and Z. And they can just have a flare up and they'll be like, oh, I had a flare up in the week and I just sat down, took some deep breaths and got some rest and went about my day again and I was okay. Versus I didn't say anything to them and they're like, oh my gosh, I felt pain and I didn't know. I thought it was the pain was back and I was getting worse because why was I having this pain? And they're now freaking out and they're panicking and their body's now tense and causing the pain to get even worse. Do you find that there's room for the doctor just being open and honest with the patient that can also help them to manage and deal with the pain that they're feeling?
Yeah, absolutely. I think, it comes back to what I call managing expectations. I
Mm-hmm.
think ultimately having an understanding of your body, an understanding of your condition, an understanding of the therapy is key to the success of that whole process of
Mm-hmm.
resolution of the issue. As you said, Kim, if you're ignorant or you lack knowledge of something, it does cause anxiety and fear.
Right,
If you think about it, the reason why people are afraid of the dark is because they don't know. They don't know
right,
what's out there. The minute you turn on the light, the same person who is afraid now is quite fine. Why?
right,
Because
fine. They can see.
that their ignorance has been supplemented by knowledge. You
Right.
see, um, so it's the same thing when it comes to issues of health. If I'm feeling a pain, does this pain mean I'm dying? Does it mean there's something wrong with my kidney? Does it mean something is wrong with my bladder or my intestines? What does it mean?
Mm-hmm.
Because pain is a signal that is purposed to indicate a problem.
Right.
Our brain has evolved to interpret pain as a signal of a problem. So if I'm feeling a pain, what is the problem?
Mm-hmm.
Do I have cancer? Do I have something, more serious going on? Did they injure something when they went in for surgery? You see what I'm saying? These are the thoughts. And now that whole process of fear and anxiety amplifies the pain because, as we said before, there's a connection
Yeah.
between all of that and muscular function. So now on top of the pain related to the endometriosis, you have
The pain
muscular
reaches
spasm,
surgery. Now you have muscle,
and
and
the
you
pain
have
related
three
to
sources of
right. So now it's amplified. So you are absolutely right that education of the patient is key. Is key to say, okay, and it's not just for surgery. Even with a medication, there are some medications that may have side effects, right? And the the side effects are expected effects of this drug. So everything that has a therapeutic effect has potential side effects.
Mm-hmm.
Some side effects are just unpleasant and are unlikely to harm you. And there are others who, if you see them, it indicates that there's a problem here. Okay?
Right.
That we're probably dealing with toxicity or some other idiosyncratic issue. So, if it is that the patient is aware of the side effects and they know to differentiate between the serious ones and just the unpleasant ones, you will find, and evidence shows this, that they are more likely to be compliant with the medications,
Yeah.
even though there may be some unpleasant effects.
Yeah. Yes, I agree. I agree. And I think we owe it to these women, especially women who they've been going to the doctors for years trying to figure out what is wrong with them. And yes, now you've given them a diagnosis and you've given them something, and that's great, but now you need to definitely set the expectation of what does this mean? The treatment options, what will that mean for you? What will life possibly look like? Because I know the doctor can't say for sure what's going to happen after. But just giving them an idea of what will happen after will save them a lot of distress, a
Yeah.
lot of distress. And when they go to the next person, because like if the doctor sends them to physio, yes, they'll listen to me, but they still want to hear it from the doctor. They still want to hear
Mm-hmm.
it from their main care provider. They want to hear it. They will believe it, especially if you're setting the tone before any other treatment. Because sometimes you're setting up the physio to fail too.
Mm-hmm.
Because now you've told them that, oh, physio going to help, physio going to fix that. And now they come to physio and like, wait. We're not going to fix that. We can make it better, make it more manageable. And they're like, no, we want it fixed. You're kind of setting up physio to also fail because we can't meet that expectation that you've now given that patient.
Absolutely. The problem in that case is that involvement of physiotherapy, the physiotherapist now is as a means of disposal as
Mm.
opposed to an
Mm.
adjunctive therapy. You see, let me break that down. You see, so when I'm talking about physiotherapy, what I'm saying and what you understand, being a physiotherapist, is that I'm saying to you that there are aspects of your care that are going to be optimally provided by a physiotherapist. So we're
Right.
saying that, listen now, yes, you have endometriosis, but what has happened is that your endometriosis, having been there for so long, is now triggering other pathologies. It's triggering muscular
Mm-hmm.
spasm of the pelvic floor, which is affecting your the lumbar muscles, which is
Right.
affecting your back, and you're now having back pain and all these things. I can treat your endometriosis, but understand that treating your endometriosis alone is not going to fix all your symptoms. So
Right.
what we're going to do is bring physiotherapy in as an adjunctive therapy, adjunctive
Mm-hmm.
or added therapy, along beside. That's what adjunctive means, right?
Yes.
To help you. That's different from saying, okay, all right, we're going to do surgery to treat your endometriosis. And then the patient comes back saying, Doc, I'm still having pain, still having problems. I say, okay, all right, let me send it to see the physiotherapist. You see? Now, the action is the same, but the interpretation is going to be different.
Different. Mm-hmm.
Because now the patient it is almost like, boy, you don't know what to do with me now. You
You're
cut me
sending me to
open, you
someone
went
else.
inside, you still don't fix the problem, so you're sending me to somebody else.
Mm-hmm.
You get what I'm saying? And God forbid now the person goes to the physiotherapist. The person is already apprehensive about whether or not something is wrong, or
Mm-hmm.
so they're not worried. It's not just about whether or not the endometriosis was fixed or not. There's also the concern of what did something else go wrong.
Right.
And then they're going to the physiotherapist, not necessarily knowing what the physiotherapist's role is. So they lack belief in the physiotherapist's ability to help them.
True. That's
You see? That's
that
it.
is exactly what
And
happens.
trust me, Kim, if somebody doesn't believe you can help them, don't waste the
You
time.
can't help them.
Don't
You
waste the time.
cannot
I've
help
had
them.
patients who I've said to them, I've actually recommended they see other persons, or actually given time they come to me for surgery, and I said, well, I'm not going to operate on you because you have not gotten to the place where you believe that this is the best option for you.
For you,
You see,
right?
and so if somebody does not believe either in you or in what it is that you're providing them, it is
It's not
best
gonna
to
work.
abstain from providing that. You see?
That is true. That is so accurate. It's the same thing for orthopedic doctors who, orthopedic surgeons who they perform the surgery. If they say from the beginning that we're going to do the surgery, and then after surgery, we're going to send to physio for the rehabilitation, that's the other aspect of your healing recovery. And they set that tone from the beginning. Patient expects that. They do the surgery, they come right after surgery with the referral, and I probably say, okay, give it a week, come back in a week, and they know that physio is a part of the treatment. They're fine. Versus surgery is done. Oh, doc, I'm having pain. Oh, okay, I'm going to send it to physio. That patient is much different from the one before.
Mm-hmm.
That knew from day one that physio is going to be a part of the care. They think that, oh,
Absolutely.
so after I pay $2 million for this surgery, no, I
That's
must
good.
come a physio. The whole healthcare is a scam. It's a money making thing.
Yeah, absolutely. No, yeah, absolutely. Absolutely. Yeah.
Yes, yes. I think that was a good one, Doc. I think it was a good one. I know a lot of women would benefit from this conversation. A lot of women with endometriosis, and they're really warriors, because I cannot imagine operating with pain constantly. Just the 1 week of your period, you want to just lay in the whole day, much less weeks before your period, during a period, after your period, pain. It
Mm-hmm.
can't be easy. It can't be easy. And that's why, even if we don't understand what persons are going through, we should give a little empathy. A little empathy goes a long way. Just tell yourself that you do not know what anyone is going through.
Yeah,
And understand
absolutely.
that most time persons' behavior and their reaction, it's not even about you, it's about them and what they're processing. And if you stop thinking that you're the center of everyone's universe and just realize that everyone's actually the center of their own universe and they're going through their own things and it really has nothing to do with you, you will have a much better experience in this world because you won't think that everyone is out to get you. Everyone feels some type of way about you. You realize that people don't even remember you when you're not in front of them.
Kim,
Like,
that's
really.
powerful. We need to do that as a show, and in and of itself, that's amazing what you're saying. That's it's spitting some serious wisdom.
But it's true. And you see people that get so irritated. And like I work in healthcare and I see the nurses get irritated with the patients. And I'm like, patients don't come here because they're happy and they want to make friends. They're sick. They come here with a problem. I'm sure the attitude is not because of you. It's not.
No, listen, what you're saying is so powerful and riveting for me, to be honest. And I'll tell you why. I love what I do. I love women's health. I think women are
Yes.
God's greatest gift.
Oh,
But
we stand.
yeah, I think women are, amazing in the sense of frail, but yet being a fortress at the same time. It's like The strength is like this balance of strength and frailty in one. And the reason why I say it is because when you think about the kind of things that I've seen and pain that I've seen women go through, let's put labor aside because everybody think I'm going to talk about labor, but I've had patients, for example, who have come to see me, Kim. And to be honest, I'm going to be honest with you. I myself wonder if there was a mental problem, and the patient is saying to me, Doc, she's in pain, and I can't even get a word in, and there's just this level of tension I'm telling you about, and people think this woman is insane, and she's going to different doctors because the ultrasound is fine, and they can then this is not really pain, is in her head, and she's seen all my doctors. And after going through with her, taking the history, going through the process I've explained, and begin treating her, and seeing the same person 3 months later, a totally different person. And she's coming back. It's like it transformed my life. I feel so. You can see the difference. The difference. The difference in her relationships, difference in she's not missing work, those things, and literally it creates a very emotional experience because you understand now, having seen women like that, and not just once or twice, you realize that there are women out there really suffering. And because people can't see the source of the suffering, they say then it's something mental and ignore them and never meet them lazy, they don't want to do this,
they
they
just
don't want to
want
do
to
that.
come work.
No one come work. I mean, you're always gonna have people who are like that. I'm not gonna say that there are not people who are like that, but there are women. The majority of the time, there are women who are genuinely suffering, and we just have to be a little more sensitive to that.
We do, man.
All right.
Power to women.
Power to women. All right. Well, Kim, that was a good one. I think we've given enough out there to help somebody today. I feel that we have achieved our goal. All right, ladies, gentlemen, hopefully I have some gentlemen watching. That's it for us for this episode of the Women's Health Podcast with Kim and Dr. C. And as usual, we're going out. We say stay happy, stay healthy.
Yes, until next time.
All right, guys, take care.